start. Just a reminder that to please enter questions at the end of the presentations. Please enter your questions in the chat, and please answer a brief survey that will be sent to you immediately after medical grand rounds, and that will let us know that you were present today. Our speaker today is brought to us courtesy of the Division of Adult Clinical Immunology and Allergy. Thank you, Chris, for suggesting this speaker today. So Michael Fein is an assistant professor of adult clinical immunology and allergy at the MUHC. He's originally from Miami, Florida, and completed a Bachelor of Arts in International Relations at Duke University, followed by a medical doctorate at Jefferson Medical College in Philadelphia. He completed residency training in internal medicine and fellowship in clinical immunology and allergy at McGill. He is currently completing a master's in evaluation of healthcare interventions at the London School of Economics in collaboration with NICE. He has a general allergy and immunology practice and works in the Primary Immune Deficiency Treatment Center. He also has a specialized clinic in immunology dermatology, seeing patients with hereditary angioedema, chronic spontaneous urticaria, mastocytosis, eczema, and autoinflammatory syndromes. His interests include medical education and quality improvement, as well as patient safety. Welcome, Michael, to Medical Grand Rounds today. The floor is yours.
Thank you very much for that nice introduction. And I'm very happy and excited to be here with you today, presenting steps from the Osler Amphitheater in the allergy division in my office. And hopefully soon we'll all be back in the actual amphitheater. And I'm excited to present you today an approach to angioedema and recent updates on hereditary angioedema. If you'll permit me, before I start, I just want to say a million thank yous to everybody who got me here today. It's a significant moment for me because it marks 10 years of being at the MUHC. I had my interview with Dr. Maniatis February of 2012, and here I am today, thanks to Dr. Soukis, Dr. Maniatis, Dr. Zanelli, Pilat. I can name a million people, and I just want to say a huge thank you. It's great to be here, and a few pictures from our good times together with mentors, Phil Gold, Dr. Schuster, and all of our administration staff and nursing and whatnot. So merci infiniment, and thank you to my French tutor and 5 French tutors for getting me here. So quick disclosures, a few educational grants, nothing directly related to this talk, and a few advisory boards. You can jot down this website at the bottom if you're interested in getting Section 3 credits on HAE afterwards. This is a program we developed with allergists, immunologists across Canada, just launched a couple months ago or a month ago. That's an educational-based program with videos, and it's a short quiz that you'll all be able to pass with flying colors after the session, hopefully. One more prelude before I get started on the angioedema update is an update on COVID-19 vaccine allergy. Dr. Copescu, Anna Copescu, presented to you last year at Grand Rounds our ARCOVE study, which is the allergic reactions to the COVID-19 vaccine, which is supported by the RI, and Dr. Isabwe, our principal investigator. We've been working hard in the vaccine clinic, assessing patients. We've enrolled over 130 patients so far, and I can say everything is going well, successfully vaccinating people with possible previous reactions to the vaccine. A quick shot of our COVID vaccine allergy clinic, and a thank you to our whole team, including Anna Iacucci, who's booking these patients, Lisa Schultz, Dale Cunningham, Mary Serge, and Faisal, who all contributed a lot to this, making this clinic a success. So thank you guys. And just a few recent publications we've done on this, successfully desensitizing patients to the COVID-19 vaccine, a series of 6 patients, and the safety of vaccinating people with possible PEG allergy. So if in doubt, you can send them our way. But yeah, we've had some good success here. And I'm just going to skip over this for time. We can go back to it if any interest later. But in summary, research is ongoing into the cause of reactions to these vaccines. So we're doing skin tests stages. And the bottom line is that most people, even if you present with a possible allergic reaction to your first dose, it's very possible that you can tolerate a second dose. Okay, moving on to angioedema. So quite frightening when you see this person in the emergency room and want to intubate them. It's a very interesting and important topic, and there's a lot of new information that's come out recently that I'm excited to share with you guys. So today I want to go over an approach to angioedema, making the diagnosis, reviewing the investigations to support the diagnosis, and then discussing the management options for different etiologies of angioedema, and especially the new treatments available for hereditary angioedema type 1 and 2. Brief outline of what I'll be going through: a definition, 2 cases, one of which I saw yesterday afternoon, which was good timing, the classification, your differential, the approach that I take, and then finally all the different subtypes and how to treat them. And I recognize that hereditary angioedema is a rare phenomenon. We don't see it every day. So I tried to pepper throughout the talk some more common etiologies and things that we see and how to treat those. So some useful tips for people practicing on the wards and in outpatient medicine. So what is angioedema? It's basically a swelling of the deep dermal and subcutaneous submucosal tissues. It's non-pitting in the case of this type of angioedema. And you can see here clearly the swelling of the lips as compared to a normal. I say step 1 is make sure it's angioedema, is because a lot of people use the term, patients even, swelling, enflure, etc. And then you finally look at a picture of what they're talking about, and it's clearly a contact dermatitis or some other diagnosis that's not a classic angioedema. So you always want to make sure you've objectified the angioedema. In general, and I'll come back to this slide a few times during the presentation, it's my approach. So firstly, I'm in outpatient medicine mostly, assessing the airway isn't the first step, but if you're seeing them in the emergency room, for sure it's airway, and ABCs, and make sure they're stable before you start wondering what type of angioedema they have. Basically, I'll go through each one of these individually, but this is going to lead you to the diagnosis, yeah, we'll take it from there. Okay, so this is a case of that I saw a few years ago. 91-year-old nun, actually, and she had typical medical problems for somebody her age, including chronic lymphocytic leukemia, not on any treatment for that. Her meds did not include any ACE inhibitors or NSAIDs, and she had presented with recurrent episodes of swelling, asymmetric eye, face, tongue, no hives, no pruritus, and she said it would happen once or twice a month, and she would take a Benadryl and it would go away in a couple hours. Interestingly, when you dig back in the notes, Dr. Schuster had seen her 10 years before, and she had hives and swelling at that time and was treated with antihistamines. And on exam, there's not much at the time, very pleasant elderly woman. The labs. So she's got a lymphocytosis, a bit of anemia, and on the screening C4 level, it's undetectable. And you do C1 inhibitor levels and a C1 esterase inhibitor functional level, and they're both markedly low. You can see less than 50% of the lower limit of normal for the antigenic level, and the function at less than 50% of the lower limit of normal. And her C1q is also low. So you're all probably thinking of the diagnosis right now as an acquired angioedema with low C1 inhibitor level and function, secondary to her CLL. And that is what we all thought at the time, but with her past history of chronic urticaria and angioedema, we put her on cetirizine 10 milligrams daily, and she had no more attacks of angioedema. And her diagnosis ended up being histaminergic angioedema with an asymptomatic biochemical C1 deficiency, which upon further reading, and I'll present you an article later, is not uncommon apparently to have asymptomatic C1 deficiency in some lymphoproliferative diseases. So the history was more suggestive of a histamine I'll get a little bit into that, but the labs looked very clearly like C1 deficiency. This is a gentleman I saw yesterday, man in his 50s who had been on lisinopril for 15 years without any issues. No family history of angioedema, no real other medical problems, not many other medications. He got a cold in October and presented with lip swelling. This was within a couple hours. By 12 hours, he looked like this and presented to the emergency room. The emergency doctors drew a C4 level at the time, which was normal, and he had supportive care, did well, and he's been off his ACE inhibitor ever since without any recurrence. And he's now on amlodipine, I think. Okay, so how do we, I mentioned histamine and bradykinin. This is how we classically separate angioedema right now. So in the histamine mediated category, these people are going to respond to antihistamines, epinephrine, steroids, and typically it's going to come with hives, but not always. So you see 10% of patients with chronic spontaneous urticaria and angioedema only have angioedema. So these are the people that can confuse us a lot. And the disease can change over time. I have an older patient who had hives at the beginning of her disease a lot and angioedema, and then she kind of got left with only angioedema for the past 5 years or so. Also important to know, these people should not be on ACE inhibitors. Any history of angioedema is a contraindication to ACE inhibitor therapy for any reason. And then we have bradykinin mediated. So this is your hereditary angioedemas, of which there's type 1 and 2, which I'll go into, and then the normal C1 inhibitor level that's hereditary, previously type 3, which is having an explosion of new genetic mutations associated with it, which I'll mention a bit later. You have your ACE inhibitor associated, you're acquired with low C1 inhibitor, and this is typically autoimmune or malignancy associated. And then finally, one of the most tricky non-histaminergic idiopathic angioedema, which is basically similar to HAE normal C1, but with no family history. So just looking at the pictures, it's a little bit difficult to say what's going on. It's really all about the history. So any of these could be an angioedema, an HAE attack, excuse me. But if you question them further, this person had a contact dermatitis to cosmetics. This lady had a neurologic syndrome called Melkerson-Rosenthal, which is a intermittent facial paralysis and like a granulomatous colitis that progresses over time. So this, and at the beginning is intermittent and then becomes permanent. And then an orbital cellulitis. So, you know, if they're having fevers, infectious process, you're going to go more here. And really it's about the history, which is difficult to take in the emergent situation, but sort of afterwards, if it's not an emergency, can help lead you to the diagnosis. So back to our approach. So age is the first thing. I know we're not seeing pediatrics, but typically HAE type 1 and 2 presents in early childhood in the first decade of life. Normal C1 inhibitor a little bit later in the 20s and 30s. Non-histamine mediated idiopathic angioedema between age 30 to 40. And then if they're over 40 years old, you're really going to want to consider acquired angioedema with C1 deficiency or ACE associated. So it's a good way to orient yourself in terms of their age and what to look for. Medications is number 2. So the second thing we want to know after how old they are is what are they taking? ACE inhibitors are the #1 cause of angioedema for medications, and you always got to check for the ACE and always have to stop the ACE if they've had an episode. Because studies show if you keep them on the ACE, their risk is high of a recurrence. And it might not be right away. And we can't test for this type of allergy, so, or adverse reactions. So it's pretty much a no-go, and you can use alternatives. Like the guy in the first case, he'd been on lisinopril for 15 years. So it's not, most of the time it's in the first couple months of starting. Interestingly, it doesn't seem to be dose related. Also, some people have postulated if it's a dose increase or an addition, sometimes an addition of a medication or sort of a second hit, a URTI, a DPP-4 inhibitor, another medication that can increase your risk of angioedema. Neprilysin inhibitors combined with an ACE inhibitor had 3 times the risk of angioedema than either alone. Estrogen increases HAE attacks and also exacerbates CSU, and I'll mention how in a little bit. And NSAIDs, a lot of our allergy consults are from NSAIDs, and so it's the second most common cause of angioedema, and it's a pseudo-allergy, so it's not IgE mediated most of the time, meaning that it's not like with the ACE inhibitor, it's not going to be every time you take an NSAID that you're going to react, which is a bit frustrating because you want to know what you're getting into. I said I'd pepper the talk with a few useful, well, daily useful information. So NSAID allergy, we see a lot of. To categorize it, people with chronic urticaria and angioedema have about a 20 to 40% risk of having a flare with any NSAID, normally COX-1 inhibitors, that's here. That's here. Then they can cause hives and angioedema on their own, and rarely anaphylaxis, or what seems like anaphylaxis. And then we have a lot of patients with aspirin-exacerbated respiratory disease. All of these are cross-reactive amongst all NSAIDs in COX-1 category. And this is patients with asthma and nasal polyps who have a flare of their asthma or have hives and angioedema or anaphylaxis with taking NSAIDs. And you can desensitize them, although it's difficult. And then rarely some delayed reactions, and single NSAID-induced reactions are quite rare as well. But hives and angioedema, common. So in terms of the family history, 75% of hereditary angioedema will have a family history, 25% will be de novo, and acquired angioedema, there's no family history. The important things to gather on the history is their previous allergic history, any previous episodes, the timing, how fast the swelling occurs. Hereditary angioedema and ACE have a relatively slow onset compared to allergic or histamine mediated. It builds up over time. So they actually, if you have HAE and you know to treat yourself, you get a prodrome. So you can treat yourself early. And then you want to ask about triggers, exercise, estrogen infection, especially any trauma or dental procedures, intubations, things that any mechanical stress in the oropharynx or respiratory system that can trigger an attack. So this is a nice flow diagram from, they've updated it recently last fall from the World Allergy Organization. On how to evaluate for HAE. So typically C4 is very good during an acute attack. And essentially if your C4 is normal during an acute attack, you have almost excluded HAE 1 and 2. If your function, your level of normal, or sorry, all decrease, you're gonna have HAE 1. You always have to repeat the test to make sure it's accurate by about a month apart. If you have just decreased function, it's going to be HAE type 2. And if you have normal for all levels, but you're having recurrent angioedema, if you have a family history, then you're going to do a genetic diagnosis. If there's no family history and genetics are negative, then it's idiopathic or possibly ACE inhibitor. So basically C4 is C1 inhibitor level and C1 inhibitor function. And then for acquired, there's a list of screening tests to do to rule out associated malignancies or autoimmune disease. Again, just for reference, there's a lot of questions regarding the specific number in terms of the decrease in C1 inhibitor level and function, and you got to be pretty low, like less than 50% of the normal level, and typically they're less than 30% for the level and the function. As you can see, ACE inhibitor entirely normal, idiopathic all normal, HE normal C1 they're all normal. So these are different pathways, but they have measured bradykinin during ACE inhibitor-induced angioedema, and it's significantly elevated. So we know it's the C3 is later on in the pathway. So it's typically normal and you don't even have to measure it. So the medication management, so histamine-mediated, epi, antihistamine, steroids, and bradykinin, I'm going to get into. There's a difference between the treatments we use acutely to stop an attack, and the earlier the better, and then prophylaxis, so long-term treatments. And this is where a lot of the major advances recently are in treatment for these patients. Okay, so we're going on to response to therapy. So typically, in terms of histamine mediated, if you're not sure and the diagnosis is questionable, we put them on 4 times a dose of antihistamines. Well, not right away, 2 times a dose and then 4 times a dose to see if we can rule out a histamine mediated process. Okay, so this is by and far the more common etiology that we're going to see, the chronic spontaneous urticaria. With or without angioedema, it's for more than 6 weeks, makes it chronic. 20 to 30% of people in their lives are going to have hives or angioedema, and 1% will have chronic spontaneous urticaria. So this is very, very common. We've learned a lot recently about the pathogenesis. It's typically an autoimmune disease. So you have allergens, autoantigens, so IgE against self that are binding your mast cell and waiting to see the thyroid peroxidase or other proteins that you have antibodies to, and then you get degranulation, or autoimmune type 2, whereas you have IgG antibodies against the receptor. This is going to present with hives. Now, it's important to know people with HAE can also have hives. So one doesn't rule out the other, but a detailed history will kind of get to the bottom of it. And typically these are going to respond to antihistamines. They're last less than 24 hours, the angioedema, and a C4 level would be normal. Just a brief note on treating CSU, angioedema, or hives. Trial of antihistamines 1 times a dose. If it's not effective, 4 times a dose. If it's not effective, you add omalizumab, an anti-IgE, which is effective in 80 to 90% of cases. And if that's not effective, you can move to cyclosporin. There's new trials for anti-IL-4 and 13, BTK inhibitors. So there's a lot of movement in this disease as well. Just a brief note, if anybody's still prescribing Benadryl, PO, it's not recommended. Patients sometimes like it because it puts them to sleep, but it's a very bad sleep. Less REM time and a lot more accidents, a lot more hangover. So Rupall, Blexten, Reactin, Claritin, there's a lot of newer antihistamines that are non-sedating. Sometimes you can try switching them if they didn't respond to one, and different people react differently to different antihistamines. So I definitely recommend a switch if you know, if they're not responding well. But second generation, or even third. A quick note, we do have a registry for CSU, started by Dr. Ben Shoshan and many others, and Dr. Elena Nechiporik in dermatology is kind of leading it now as well. So if you have CSU patients, we're studying long-term outcomes and associating with autoimmunity. So you can send them to Derm or to us for enrollment. Okay, on to HAE. So this is now a much more manageable disease. I would say previously still probably terrifying, but much less so now with all the new treatments we have. This is completely unpredictable. You know, you could be out at a party, you're out having dinner, you're doing your normal routine, and from one moment to the next, you're completely swollen and your life is in danger. So very fortunate to have the new treatments we have. The reason for the picture of Osler earlier is that he's the person, he didn't discover it per se, but he's the one who discovered that it was an autosomal dominant inheritance. So Quincke from Quincke's edema was the first to recognize it in 1883, I believe, with a little case series. And it was actually one of his graduate students who I think wrote up the case in 1885. And then Osler described a big family of like 25 people in 1888. And basically, as I've already alluded to, it's a deficiency of plasma protein C1 inhibitor, and the swelling is caused by excessive bradykinin. This is one of my favorite pictures I found when starting for the talk. So Osler, I think he was in Maryland actually in this picture, but he's observing, he's palpating, he's auscultating, and then he's thinking. So thinking, the most important step. And just a brief timeline of where we are today. And I could have included a few more things recently with the new genetic diagnoses, but you know, the C1 deficiency wasn't recognized until the 60s. But now the knowledge is moving at a rapid pace, and there's a lot of interest and a lot of, like I said, new treatments available, very targeted to the specific defects. So I mentioned it's a rare disease. 85% are going to be type 1, 15% type 2. And with the normal, it's even more rare. So less than 300 cases, it might be a little bit more now. We don't actually know the true prevalence because we all see these patients who have angioedema. Occasionally, we work them up head to toe and can't find anything. So there's probably underreported. It's a relative frequency of 1 in 50,000 for HAE type 1 and 2, and 1 in 150,000 for normal C1, with factor 12 being the most common, but on its own, pretty rare. And de novo mutations making up 25%. So it's on the C1 inhibitor comes from the chromosome 11, the SERPING1 gene. It's very similar actually to alpha-1 antitrypsin. It's a protease inhibitor that binds enzymes and basically degrades them. There's a very high penetrance, about 95%. I did have an interesting case recently where I saw a referral of a man in his 50s, or I think he was in his 50s, whose mom had it, and like half of his family had it. He had somehow never been tested, and but his daughter had it, supposedly. It turned out that he didn't have it and the daughter didn't have it either. So it goes to show you definitely need to repeat those tests. The daughter was diagnosed with 1 lab test and 1 attack, and she hadn't had anything for like 15 years. So it's much easier explaining than other explanations because it doesn't skip a generation. A lot of mutations in the SERPING1 gene, over 700, so lots of heterogeneity. There's your protein. There's a reactive loop center. So the mutations in the protein itself, where the 650 are, that reduce your levels because you don't get a good protein and it's destroyed. If you have a mutation in the reactive loop center, then you have protein levels, but it's a functional deficiency, and so that's type 2. I won't go through this too closely, but this is just to show you the relationship between the complement pathway, contact activation pathway, where bradykinin is formed, the coagulation system and the fibrinolytic pathway all interact with each other, and C1 inhibitor is the brakes on all of them. It's interesting that there's not, increased bleeding or thrombosis or other issues for patients with HAE. It's really related to the swelling and the bradykinin. And basically, you get factor 12 activated, leading to cleavage of high molecular weight kininogen by kallikrein with release of bradykinin, binding to its receptor on the endothelium and causing swelling. This is just to show you, so bradykinin binds the B2 receptor, signals downstream to release the tight junctions, and fluid goes, leaves the vessels. And it takes a while to absorb, so it's 2 to 5 days. That's why it takes a long time to improve. This I thought was interesting because you can see here the bradykinin molecule. It's catabolized by many different enzymes, including ACE, DPP4, of which you know we have DPP4 inhibitors, APP, carboxypeptidase. So there's a lot of different enzymes that are working to degrade bradykinin, and there might be different variations in many of them that could be multifactorial in producing angioedema. And you can see here the relative strength of the enzymes, ACE being by and far the largest. And also estrogen is in the promoter region for coagulation factor 12. So when you have increased estrogen levels or you're taking estrogen, you get increased factor 12. You also get decreased APP and a few other effects that lead to increased risk of swelling. So the clinical features, I'm doing for time, okay. Basically recurrent angioedema without urticaria. I put the asterisk because, as I said, urticaria is common, so people with HAE are allowed to have hives as well. One of my patients with HAE has HAE type 1 and incidentally also has cutaneous mastocytosis, urticaria pigmentosa, two rare diseases in the same person with no link. So you can't close your eyes from one to the other. But basically asymmetric, non-pitting, non-paritic. It can start in type 1 and 2 with a erythema marginatum, like a serpiginous macular erythematous rash and tingling and burning. I've had a patient take a picture. It was the same patient who took a picture and emailed it to me. Said, "What should I do?" Because she hadn't had an attack in a long time. I said, take your fears here. Laryngeal attacks are less than 1% of all attacks, but there can be over a 30% mortality rate. So very important to treat all laryngeal attacks. And all patients should have on-demand therapy to treat acute attacks. Recurrent abdominal pain as well. You can have some suspicion. We've had diagnosis in people with well, not me, but people, and I follow them now, HAE type 2, who had recurrent abdominal pain, a lot of ER visits. You can see bowel wall edema on the scans. And then it resolves in 2 to 5 days. So if this is the presentation, you definitely check a C4 during an attack to see if they might have HAE. This is a very busy slide, but it's just to highlight the new genes associated with a normal C1 inhibitor HAE. So it's factor 12, plasminogen, angiopoietin-1, kininogen-1, and myoferinine. And as you can see, or maybe you can't see because the slide's too small, but this is much more female predominant. It presents a little bit older. There's more facial and oral attacks as opposed to abdominal as a group for the normal C1s. I'm definitely, these are very busy, but just to give you an idea of all the diverse pathogenic mechanisms, factor 12, if you have a factor 12 mutation, it can be more susceptible to activation from anionic surfaces and tissue damage. You get more factor 12, you get more bradykinin. Plasminogen, the mutant plasminogen, can increase your plasmin levels, which again increases the factor 12 activation. And finally, if you have a mutant kininogen-1, your high molecular weight kininogen, which gets cleaved and releases bradykinin, it actually releases a abnormal bradykinin that's more resistant to degradation and hangs around. And finally, endothelial functioning. So angiopoietin 1 gene. So if you have a mutated angiopoietin, you get defective signaling and through multiple pathways, increased vascular permeability and angioedema. And then myoferinine 2, which has to do with VEGF recycling, and you get increased VEGF recycling leading to angioedema. So a lot of different pathways. Again, just to highlight, I have 40% here, I had 50% earlier. It's between 30 to 50%. So for the normal C1 inhibitor diagnosis, this is consensus criteria. So you need recurrent angioedema without medication causes, normal C4 or C1 levels, documented lack of response to high-dose antihistamines. You either have to have a known genetic mutation or a family history. So if you don't have all those four, then you have idiopathic angioedema. Okay, so what's new in HAE? This is what's very exciting, and it's just been really nice to see my patients go from danazol or androgens, which they had been on for some time, tons of side effects, which I'll talk about, to C1 inhibitor intravenous, to C1 inhibitor sub-Q, to lanadelumab, which is the newest, well, one of the newest monoclonal antibodies. So these are just life-changing options for patients that allow them to be a lot more secure and have a lot less side effects. So there's international Canadian guidelines. These are from 2019, but they're pretty similar now, which is the first line preventative therapy is going to be subcutaneous C1 or lanadelumab. They've added recently berotralstat, which is an oral kallikrein inhibitor. These of note are available in Canada. They're not available everywhere. So in many parts of the world, people are still taking tranexamic acid and androgens. They're cheap, they're orally available. Here you have just a nice summary of all the treatments available. Again, important to remember the difference between acute treatments and long-term prophylaxis. So IV C1 is going to be used for acute treatment at 20 units per kg, and for short-term prophylaxis before any procedures. And sub-Q C1, plasma-derived C1 is going to be for long-term prophylaxis. So lanadelumab, I will say most of my patients have transitioned to this medication in the past year, and doing very, very well on it. It's a fully human monoclonal antibody that inhibits active plasma kallikrein. It's approved by Health Canada. It was by compassionate use for the past year, and I received word that it's recently, I believe, going to be provided by Hema-Quebec, so it's covered for patients for type 1 and type 2 HAE. And basically, you just prevent cleavage of high molecular weight kininogen by kallikrein. The trials were very impressive. They had 125 patients, this is from 2018, with pretty moderate severe HAE, and to a few different doses. The dose that ended up winning out is 300 milligrams every 2 weeks, which reduced the attack rate by 1.71. So 2 per month in the placebo and 0.26 per month. And you can see the degree of severe attacks in the placebo versus the 300 milligrams every 2 weeks. This is something they give themselves at home. And after 6 months, if they've had no attacks, you can move it to every 4 weeks. And for most of my patients, I've done that. I just like this slide because this is each line is an attack, and the color, you can't really see it that well, but if you just take a global shot, the placebo is just, they had tons of attacks before the study period. They had tons of attacks during, no real change. And this, every 2 weeks, you can just see lots of attacks beforehand, and then they go to nothing, except for there's a couple patients that didn't respond well. Adverse events were very minimal. It's mostly injection site pain. No serious related adverse events. The serious unrelated adverse events were like bipolar disease and things that were unrelated to the study drug. This is what motivated me to start changing people from androgens who had been on androgens, some of them for many years. One person, was like, had gained a ton of weight, had no libido, was depressed, their cholesterol was through the roof. I send them to endocrinology and they're doing much better in many of these regards. But we had to get him off androgens, and now doing very well on lanadelumab. There's a risk of liver cancer. You need a yearly ultrasound. So This is, if you have nothing else, it's a good option because it works very well to control the angioedema. But there's just so many side effects that it's not ideal and not to be used in children or pregnancy. So subcutaneous C1 inhibitor, before when I had a bunch of people on this, it's twice weekly. You can see here the relative risk of an attack compared to their functional level of C1 activity. The baseline, about 25% for participants in this trial. And then with 40 units twice a week, they go to 40% and 60 units to 48%. And this is going to lower your attack rate, you know, from like 80% risk to less than 20%, I would say. And they had a 95% attack reduction versus the placebo. These people had a lot of attacks. I think they needed 4 attacks or something like that in a 3-month period before being enrolled. So this was a severe group. I should mention that some people don't need any long-term prophylaxis because they get an attack once every year, once every couple years, and they've never had a laryngeal attack. So it's a very personalized decision with patients whether or not they want to go on long-term prophylaxis, and it could change depending on, you know, what their attack rate is like and their effect on their quality of life, their disability, fear, things like that. So finally, what everybody's asking about now is an oral pill that's a kallikrein inhibitor. It's a small molecule approved in the US and available. Not available in Canada yet, but probably will be in the near future. It's a berotralstat. So I'm doing for time. Okay, I got 4 minutes. They randomized people to 110 or 150 or placebo, 6 months of treatment. They needed 2 attacks in the run-in period, and they couldn't be on long-term prophylaxis for 2 to 4 weeks beforehand. And you can see here they have a nice reduction in investigator. They had about 3 at baseline, and then placebo compared to the 150 milligram group had about a 45% reduction in attacks. They didn't actually comment on severity of the attacks, which I thought was interesting, but a pretty good response. The international guidelines don't say whether or not the first line is this oral pill, the lanadelumab, or sub-Q inhibitor, and they haven't commented on. There's no head-to-head trials, obviously, but if you extrapolate a little bit, the lanadelumab and the sub-Q inhibitor seem to do a little bit better than this. And finally, future directions. They just published a phase 1 first-in-human randomized dose escalation study of anti-activated factor 12 monoclonal antibody. It's called garadacimab. And they did sub-Q and intravenous formulations, found 48 healthy male volunteers and gave them 1 dose, followed them in the hospital for a couple of days and then at home for 85 days. And the results were very promising, very safe. There was an increase in PTT, but not PT, and no bleeding. And then headaches were the same in each group. And basically it was, again, like most injection sub-Q medications, erythema and some pain locally. So far in this phase 1 study, it looks to be very safe. And it's very good by inhibiting factor 12, an activated factor 12. You get very good kallikrein inhibition, near complete at 3 mg per kg and complete inhibition at 10 mg per kg. And it's sustained for a month, so this could be monthly dosing as well. So great to have possible more options. We've already come quite a long way. Oh boy. Okay. With 2 minutes, I just want to tell you about acquired and angioedema and ACE angioedema. You guys are going to have enough angioedema for a lifetime after this. So this is rare. It's 1 in 500,000. So exceedingly rare. Could be underdiagnosed. This study I mentioned earlier, when I was thinking about the patient we had who had CLL and low C4 and C1 inhibitor levels and function. This group, Becos, in 2016, they did a retrospective study and looked at 131 of their lymphoma patients and found a surprising number had C1 deficiency. 10% of their DLBCL patients and 4% in CLL. It was only one CLL group. But that only 3 out of the 14 who had a lab diagnosis were clinically symptomatic. And then they did follow-up studies, and most of these people improved or normalized their C1 levels with treatment with rituximab or R-CHOP. The only people who didn't improve were those with small marginal zone lymphoma that had a splenectomy, and taking out the spleen didn't cure the C1 deficiency. But you can see here, there are different types of lymphoma, and they looked at 131 cases, and 14 had C1 inhibitor deficiency, and only 3 were symptomatic. So we don't routinely measure this in patients unless they're symptomatic. So very interesting for our patient, the 91-year-old who had this deficiency. She had CLL, but didn't have any symptoms, and her angioedema was from histamine. Typically related to autoantibodies against C1 or consumption by neoplastic tissue. The swellings are very similar to HAE, but it's less GI and more facial lips. And again, older age of onset and a negative family history. Treating the underlying disease is the mainstay of therapy. And like I said, most of the time it's going to resolve the C1 deficiency. They can be resistant to C1 because of the autoantibodies, but icatibant seems to work very well. And finally, I'll close with the ACE inhibitor angioedema. So it's relatively common, 0.1 to 0.7% of patients treated. I read it's the global amount of people on ACEs is astronomical, much more common in African Americans, and this might have to do with genetic polymorphisms in bradykinin metabolism. It's the main culprit of drug-induced angioedema in the US, and it's 20 to 40% of all ER visits for angioedema. This is going to affect mostly the face, the lips, the tongue, the uvula, and the upper airways. Not sure why. Typically, again, within a month of treatment, but can happen at any time, and often with the introduction of new medications, as I mentioned. And you can have a washout period where you get a few more attacks after stopping the ACE. So this is important because I typically recommend not starting an ARB during that period, because in case you have a rebound effect from the ACE. So it's basically supportive care. If you can, check a C4 level and discontinue ACE indefinitely. A lot of treatments have been tried. There's no real recommendations except for that if they present early within the first like 2 to 3 hours, you can try icatibant or C1 or solvent treated plasma, because it could have an effect early, but recent randomized trials, 2 recent randomized trials showed that there was no effect, but they could have presented up to 12 hours. So basically by 12 hours, the angioedema is there and nothing medication you give is gonna help turn it around. Here we have this is a Danish study. They looked at a registry of a lot of people, over 1 million people, who had taken different antihypertensives, and basically found, this is what I was talking about, if you had an episode of angioedema and continue an ACE, your risk of having a future episode was 1.5 odds ratio. Whereas if you switch to an ARB, you were much less likely to have an angioedema at 0.4. And the other drugs were kind of close to the confidence interval past 1. So, you know, not less or more likely to have another episode of angioedema. So bottom line is we think ARBs are safe for patients with history of angioedema to ACE, but wait 4 to 6 weeks before starting it. Medical alert bracelet, and definitely inform and educate the patient. just to remind you of our approach, age, medications, the history, mostly about the history, lab, C4, C1 inhibitor, level and function, the management reviewed, and always thinking back how they responded. And in conclusion, the history is key. You want to think, is it histamine mediated? Always check the medication list and ask them specifically, did you take an Advil, an aspirin, an naproxen, etc., and estrogen use? We need to keep a high index of suspicion for HAE and acquired because it's rare and it often goes undiagnosed for a decade, even now. So with the history in mind, if you're I have very low threshold to check a C4 just to reassure myself. And in acute situation, definitely manage the patient, but check the C4. And remember, we have lots of great new drugs available that's really improving the quality of life of these patients and reducing attack rates and whatnot. So that's about it. Oh, I did want to just briefly mention, I have 1 minute, medical education project we're doing in allergy immunology that we were working on for a couple of years. So we worked as a department, we just published a little pocket guide on allergy and immunology, and we're using this as a backdrop to develop a new curriculum for rotating residents. So this is also a plug, rotating residents. We'd love to have you in allergy and immunology, and you can look forward to new and exciting information, seeing these patients, and getting a curriculum. We also are doing a survey pre and post with the PGME to judge how residents are faring during their rotation, and how they feel their knowledge assessment is during the rotation in many different areas for us to identify where we can improve. So this is a little QI medical education project we've been working on. And if you'd be interested to collaborate with your own division, feel free to reach out to me. So that is all I have. Thank you very much.
Thank you.
I hope I wasn't talking too fast.
Perfect. Thank you so much, Michael. Very interesting. Very interesting topic. And actually, we have a few questions here, so I think we'll get right to it because we don't have too much time left. Dr. Rosenblatt wants to know, since many of the hereditary cases are de novo, what are your criteria for molecular testing, and what tests do you order?
So it's a very great question. And so basically, I've had a couple of patients who meet the clinical criteria very well. So if the swelling is, lasting 2 to 5 days, it's happening after a dental surgery, there's no hives, it's really kind of seeming like a very typical case of bradykinin-mediated angioedema. I do genetic testing. You can do for SERPING1, which is going to be normal because the C1 levels are normal for most of the part, and then the new genetic markers that are available. And you can also, I've sent some bradykinin assays to France. In Grasse, France, they do like ACE inhibitor, like functional assays for enzymes breaking down bradykinin, but it's I've sent it for 2 patients and it was not too helpful. But basically, if they have no family history, but a very strong clinical history, I'll send it.
And Michael, do you follow up on family members when you have a positive result?
Yes, definitely. It's you 100% have to test all family members. Because of that 5 to 10% that don't present, and they might only present when they take an ACE later, or there's some second hit. And this was kind of the interesting one when I had a gentleman in his 50s who literally had a huge family. The mom who had it had 14 children, and half had angioedema, which would make sense. And he had never been tested. So definitely we got to test all family members if you have a positive case. And
you think that in the future molecular tests will be done earlier in the workup? Is that the future what awaits us?
I think so. I definitely think so. Especially as we learn more and they become more available. Yeah, this is all very recent.
In acquired cases due to lymphoma, does C4 return to normal or stay chronically low?
It will return to normal if it's treated. So the two groups, if lymphoma is treated, depends on the lymphoma. So if the one case was the splenectomy, if you had marginal zone lymphoma and it was treated with splenectomy, but if you had R-CHOP or rituximab or other chemotherapeutics, it typically did return to normal.
Michael, for all the clinicians here who see patients who present with a rash, whether you're in the emergency room or in your clinic, what's your decision to whether you're sending to immunology or dermatology based on history or physical exam? What do we do here at the MUHC?
I like that. That's a good question. It's a hard one to answer. I would say oftentimes we both end up seeing the patient. And for good reason. If you need help in antibiotic selection and the rash is thought to be secondary to medication, maybe we can help a little bit more with that. Dermatology also can help with that. So there's a lot of overlap. I don't know. Sometimes if you call one of us, they'll recommend calling the other after seeing the patient. So I don't know, it's a tricky one to answer. We're both happy to see the patient, so.
You don't do clinics together. Could you ever imagine that?
We're starting, actually. It hasn't, we're Dr. Carolyn Jack, who has a special interest in eczema, and Elena Nechipura, who has a special interest in mastocytosis and chronic urticaria. We're definitely linking up and talking a lot and want to get a multidisciplinary clinic going. But yeah, the talks are there.
Fantastic. Just one last thing. So before we start patients on ACE inhibitors, do we always have to get the family history? Because we use, cardiology, we start patients on ACE inhibitors routinely. I don't think in our guidelines it says, or I've never seen it, written that you should do a detailed family history for angioedema with the ACE inhibitors.
No.
Think about that.
I can't say that I've seen it recommended anywhere either. The only thing that is recommended is that if the patient has a personal history of angioedema, that they have a contraindication to ACE inhibitor. And I don't know, when I was in prescribing ACE inhibitors, I don't think that I ever asked that question, but it probably would be a good screening question. Have you ever had it? Because they can have it as part of the chronic urticaria, which is quite common. And it just makes me uncomfortable having them, on an ACE with a history of personal angioedema, even if their C4 is normal and they don't have HAE. So I don't think you need to ask about a family history, but personal history.
Okay. Chris Took has asked here, he's asking, is the preference of cardiology or of ACE over ARB? I think it really, it depends, but I can tell you cardiology is big on ACE inhibitors. We have a lot, for instance, in heart failure, we have a lot of clinical trials where ACEs were used preferentially over ARBs. So I think cardiology is still a big user of the ACE inhibitor, more so than the ARB. But obviously this is a sort of a lingering concern in the higher risk patient, and probably ARB needs to be used, considered in the higher risk patient, certainly. We're coming on the hour, so we're gonna have to stop there. Thank you so much, Michael, Dr. Michael Fein. Thank you so much for presenting today. Really, really interesting topic, and great to see progress being made in this area. And I'm happy to see that you're putting your training in healthcare intervention and quality of care already to the test, and we hope to see more of that in the Department of Medicine as time goes by. Thank you so much for presenting today, and thanks everyone for joining us. Have a great afternoon.
Thank you.
Thank you. Bye.